Just to let you know, we are recording. And I welcome you. Good afternoon, and welcome to UT Southwestern's O'Donnell Brain Institute's Total Care for Parkinson's Disease community event. We're excited to continue with our series, Ask Your Doctor, and we are glad you could join us today. This session is hosted via a Zoom webinar, which differs from our previous meeting format. The key change is in how attendees interact with the speaker and the host. So to submit a question or a comment, please use the chat icon located at the bottom of your screen. You may type your message at any time during the presentation. The moderator will present the question or comment to the speaker at the appropriate time. If you do prefer to speak, click Raise Hand. When prompted by the moderator, click Unmute to share your question live. Speaking of live, this is a very important note. This session is being recorded. By participating, you consent to be included in the recording. If you prefer not to be recorded, we recommend using the chat feature instead of speaking live. So with that little bit of housekeeping complete, I'm pleased to turn things over to Dr. Sood to begin today's presentation.
Thank you, Janice, and welcome all. We are excited to welcome you all to our second Ask Your Doctor series. I am Anupa Sood, and I lead the Total Care program at the O'Donnell Brain Institute at UT Southwestern. The Total Care program, if you are new, you can always go to our webpage, and I will send you a link for that here in the chat in a minute. And you can look at all of our series events that we're doing. There are virtual events that we do every month, but we also have some in-person events that you can attend. In December, we'll have a Dance with PD event, and it'll be very festive and fun. So I hope you can attend. And then we have our April annual symposium, for which we do, a half day presentation and, conversations that happen right here on campus at UT Southwestern. Now, with that, I am going to introduce you all. I'm sure some of you know her, Sarah Smith, who is a board-certified physician assistant here in the Movement Disorders Clinic at UT Southwestern Medical Center. Dr. Smith earned her doctorate degree in biology with a focus on neuroscience from UNT in 2012 and a Master of Physician Assistant Studies from UT Southwestern School of Health Professions in 2018. She's a member of the American Academy of Physician Assistants and the Texas Academy of Physician Assistants. And today she is going to speak to us about levodopa-infused therapies. So welcome, Dr. Smith.
Thank you very much. Thank you for welcoming me. I'm very excited to be here and to talking to all of you about the levodopa infusion options. I think I'll start my slideshow now, if that's okay. All right, just one moment while I get that pulled up. Okay. All right, are you all able to see my slideshow now?
Looks good.
All right. Thank you very much for that introduction. I am so excited to be here today talking to all of you. And Dr. Sood's introduced me, I'm Sarah Smith. I'm a PA here in the Movement Disorder Clinic. I've seen many of you, and many of you I haven't seen. If I haven't seen you in a patient room, I maybe have seen you in the hallways. And if I haven't seen you, I'd love to meet you. So I'm just excited to get to know all of our patients. This really is truly a passion of mine. And so this being a passion of mine, I'm very excited to talk to you all today about some of the options that are now available for the levodopa infusion therapies. And with that, I'll get started. So levodopa infusion therapies. Lots of questions. Why would you do it? Where would you get it from? Where would you put it? What, when, how? I'm going to try and answer all of these questions today. So first, just a little bit of background. So I say Levodopa Infusion Therapies, but I can't talk about Levodopa without talking about carbidopa. So we're going to start with what is carbidopa levodopa. It's a word all of you guys, or two words all of you guys have probably heard. It's a tongue twister. Say it all the time. Some people have little nicknames for it, but carbidopa levodopa is the gold standard of treatment for Parkinson's disease. It has been since the 1970s. This drug, this medication, specifically levodopa. So when we're talking about carbidopa, levodopa, we're talking about two different medications here. That levodopa is what we would call the active ingredient. So that's the mainstay treatment for Parkinson's disease. What it is that levodopa is transported to the brain into those dopaminergic brain cells, and that's where it's converted to natural dopamine. And so kind of, again, the history of the disease is in Parkinson's disease, you don't make enough dopamine. So we're here to provide that dopamine to help reduce symptoms. So what's that carbidopa for? And I want to bring this up because we always see those two together. So carbidopa essentially is helping that levodopa get to the brain because that's where you need it to be converted to dopamine. So these two medications work very well together in helping get the brain cells the dopamine they need. So when we're talking about carbidopa, levodopa, we often talk about dosing because this is a multiple times a day medication. Many of you guys might be on the oral forms where you're taking the carbidopa, levodopa multiple times a day, and we're always talking about the dosing and the time of dosing. And the reason we talk about it like this is because carbidopa, levodopa has what's called a short half-life. Whoops, let me turn these lights on. A short half-life, meaning it doesn't take very long for the body to either use all the medicine you take or for it to be cleared from the body. So that means it just doesn't stick around very long in the part of the brain where we need it to be active. And that's why you have to take it multiple times a day. So there's always a lot of questions associated with the dosing of your medication. We spend a lot of time in appointments talking about the dosing of your carbidopa, levodopa. A lot of questions. Why does it not last as long? Why do I have to increase my dose? Is there a longer acting version? So all of these questions start to come up as we're going through the process of talking about the dosing of the medication. So because it has a short half-life and because we have to give it to you quite frequently, often you're taking the medicine quite frequently, which is why there's been a push to develop ways to infuse or give the levodopa more frequently, more effectively. So that's why we've developed levodopa infusions. And so there's different types of levodopa infusions, and I'm going to talk about all of them today. Not talking about any one as I'm promoting this as I'm getting paid from the drug company to tell you about it, but I'm giving you the options that are out there. And at the end of the day, the option that is best for everyone is going to be different for everyone. So as I present these all today, you might find things you like about one, things you like about another, or you're just here to listen to hear what options are there. But often the question is which device or which levodopa infusion device is best for me? And that's going to vary. Or maybe even an infusion device isn't best for you yet. And so that's the one thing about this process of discussing with your provider all the different ways to get levodopa into your system. There's a lot of options. There's a lot of answers. There's a lot of ways to do it. And sometimes there's a right way for one person that might not be the right way for another. So on this slide here, I'm just showing the different types of ways to get levodopa into your system. You can take the pills. And we also have the Vylev and the Duopa. And I'm going to talk about each of those as we get through the talk here. So the two options I'm going to talk about today are Duopa and Vylev. And these are the names of the devices that deliver the medication. So the first one I'm going to talk about is Duopa. And it's the first picture you can see on the slide there. And Duopa is a gel. It is delivered via a J tube. A J tube is also called a jejunum tube. It looks very much like a feeding tube. So in Duopa, the tube is actually inserted into the abdomen through the stomach, and then a little bit of the tubing, so this is an example of the tubing here, actually goes all the way into the jejunum. And so this is going to bypass the stomach. The tubing is going to go through the stomach and into the jejunum where the medication is going to be delivered. So this is approved to deliver medication for about 12 to 16 hours a day. The other option is Vylev. This is a liquid form, so it's not a gel, so it's a little bit thinner of a liquid. It's delivered instead of through a feeding tube, it's delivered through what's called a cannula, which is essentially a needle and a Band-Aid that injects into the skin, and it delivers the medication. And this is an example of it. If you can see my screen here, it's much smaller. And then the tubing itself is also much smaller. But this does not require a procedure, but it is changed. The cannula itself is changed by the patient. Whereas in the Duopa, that tubing is placed as a procedure, often an outpatient procedure, by a gastroenterologist or interventional radiologist who places it. So the difference is in the Duopa, you're having that procedure done in an office by either an interventional radiologist or a gastroenterologist, whereas in the Vylev, it's subcutaneous, so it's outside the skin, and it's changed about every 2 to 3 days by the patient or someone with the patient at home. Like I said, Duopa is FDA approved to deliver medication for about 12 to 16 hours a day. The Vylev option is going to deliver medication up to 24 hours a day. So this Vylev option, this is the Vylev option. In the second picture on the bottom is the Vylev. This one you can sleep in. So this is going to allow medication to be delivered 24 hours a day. And we can talk a little bit more about what that means for you as a patient. So the next question is, who's a candidate to get these options as a way to, instead of doing your carbidopa, levodopa through pills, how can you be a candidate to have your carbidopa, levodopa delivered either through the subcutaneous Vylev or through the J tube in the Duopa? So in Duopa, the requirements are you have to be levodopa responsive. So you have had to have tried oral levodopa and your Parkinson's symptoms respond to levodopa. You have to have advanced Parkinson's disease. PD means Parkinson's disease. I sometimes use that acronym. And you have to have what's called motor fluctuations. Motor fluctuations are that essentially what it means is your symptoms fluctuate through the day. And the reason we say motor fluctuations is because carbidopa, levodopa primarily treats your motor symptoms. Slowness, stiffness, tremor, sometimes some freezing and gait, but often not as robustly. But it's primarily focusing on the motor symptoms. Something else we say when we say motor fluctuations, when you are on your carbidopa, levodopa, sometimes you get what's called peak dose dyskinesias. So a dyskinesia are those involuntary movements. Sometimes patients will get those. Not everyone gets the dyskinesias. And then as you're wearing off, your Parkinson's symptoms start to come out. So the reason that the Duopa is there to reduce those, what we call motor fluctuations. You have to have at least 3 to 6 hours of off times a day to be a candidate for the Duopa. You also have to have shown that the oral therapy options were not sufficient to treat your Parkinson's symptoms. And that kind of goes back to the 3 to 6 hours of off time or the motor fluctuations. And that's essentially saying if you meet those 2 bullet points, you've essentially failed your oral therapy. Also, you can have no contraindications. So contraindications meaning no medical reason to say you cannot have a tube placement. So the gastroenterologist, you have to be seen by a gastroenterologist, and they have to say it's okay and safe to have the tube placed. Now switching gears, who is a candidate for Vylev? Vylev, again, is the subcutaneous version versus the Duopa, which is the intestinal gel. The subcutaneous Vylev requirements are you have to also be levodopa responsive, meaning you have tried the oral medication and your Parkinson's symptoms respond to it. They require greater than 2.5 hours of off time a day. That's total in 24 hours. So this is an example of off time a day, and I'll go more into the on and off periods. But by 2.5 hours of off time a day, we add it all together. So say, for example, when you take your medicine in the morning, say you take your first dose of carbidopa levodopa at 7 a.m., and it takes 30 minutes to an hour to kick in. And then once you kick in, meaning the medicine starts to work, you can feel your symptoms reduced. We say now you're on. And then say your next dose of medication is not until 1 p.m. If perhaps you wear off around 11 or 12, now you have an hour when you first took your medication of off time, plus an hour of off time when you're waiting for your next dose. Now we can say, well, there's a 2-hour window of off time. And as you can see, we can add it up over the day and then make those, and then we can document your off times. You also have to have the motor fluctuations. When you're on, your symptoms are well controlled. And then as you wear off, they're not as controlled. And these are those fluctuations throughout the day. It's often shown in a sinusoidal type wave on a graph. You also can have peak dose dyskinesias, but it's not required for the Vylev. Again, you have to have failed oral therapies as well, meaning if you're having these fluctuations and you're having this amount of off time a day and you've done your best to optimize your oral medication, then that bullet point of failed oral therapies can be a checkbox. The other thing that Vylev does require is to try other adjunct medications. Adjunct medications are medications that are sometimes prescribed in addition to carbidopa levodopa. So sometimes carbidopa levodopa needs some helper medication. Not going to get too much into the oral medication options today. I really wanted to keep this talk focused on the infusion therapies, but that's just why that asterisk is there. So what is on time and what is off time? And we use these words all the time in the office, and sometimes they can be confusing, especially if you don't really have these distinct on and off periods. So what is an on time? On time means you're on the medication and when you feel your symptoms have improved. So this on time can vary throughout the day. So this is when it can mean that the on time can fluctuate, and what is on for one person might be a different symptom or different sensation than someone else. So this on time is very different from everyone. So what is the off time? This is you're still taking the medication, but your symptoms are not improved. And that's the key here, is so that you're taking the oral medication. However, your symptoms are not well controlled. This can also fluctuate, and this is still different from everyone. We use the terms on and off very vaguely because everyone with Parkinson's disease is a little bit different. And so someone might have a tremor, and another patient with Parkinson's disease might never have a tremor. So the distinction between one person's on time with a tremor is going to be very different than someone's on time without a tremor. And that's why we use kind of these vague words, because everyone is so different. And so kind of think about to yourself, what does my on time feel like and what does my off time feel like? And in addition to everyone not having the same on and off, not everyone may have this robust on and this robust off period. And that's okay, because everyone is a little different. But this is just to kind of distinguish the on and off periods, as it's very important when discussing these options, these infusion options, these advanced therapy options, because these options are available for patients that have fluctuating between on and off. Most important thing is, what are your expectations with an infusion therapy? And one thing that is so important to say here is that you are not any better than your best on, even when you're on these therapies. And what I mean by that is we can never create a better on period with these infusion therapies than the oral medications. However, we can give you less off times with fewer fluctuations. We can reduce the pill burden. We can allow you to have more options for food intake, because with these infusion options, either the subcutaneous, which means it's through the skin, versus the duopa, that's the intestinal gel, we're bypassing somewhat the need to worry about food's interference with the carbidopa levodopa. And that's a big part of, as those, some of you may have now been had the disease long enough to recognize that food can interfere with the medication, and so that food and mealtime can greatly influence what your on and off time looks like. Sorry about that again. So with the expectations of these infusion therapies, it's important to know the biggest thing is that we cannot make you better than your best on, but if we're reducing your off times and we're taking away a lot of these other factors, the pill burden, the mealtime fluctuations, that even though we're not making you better than your best on, we're at least increasing your on time, which will improve your overall quality of life if we can get these therapies to work properly. So why would you do this? Why would you choose to want to do one of these infusion therapies? And so the most common one is to improve the on time, then reducing the pill burden, reducing those motor fluctuations. Like I said, that while you're having these motor fluctuations are highly dependent upon the medication being absorbed through your intestines when you take it as an oral form. So you often have these motor fluctuations because of the short half-life of the carbidopa levodopa and how the digestive tract absorbs and then brings that levodopa to the brain where you need it. One thing I want to say is that, why would you do this? For some people, it's better sleep. For the Vylev, which is the subcutaneous version, this can be worn for 24 hours a day. And because it's worn for 24 hours a day, for some people that allows for better sleep. Also reducing the food, interfering with the absorption. We talked about that, how food can interfere with the absorption of the carbidopa levodopa. So by reducing the oral route of taking it, you can reduce some of the food interfering with the absorption. The last two bullet points I have here are swallowing issues and absorption issues. So for some people with Parkinson's disease can affect the muscles that control your swallowing and your voice. And so these options are also great for those of you that have loved ones with Parkinson's disease that have trouble swallowing pills. These devices allow us to bypass that need to take pills by mouth. Also, for some of you guys have a lot of constipation. Constipation is a very common symptom of Parkinson's disease. Constipation is also a side effect of the carbidopa levodopa in any form. And we know that when you're constipated, you might not be absorbing all of the carbidopa levodopa. So if you're also battling a lot of constipation, these options can help reduce the absorption issue with that. Now, I'll say at the end of the day, we want to make sure you're not constipated, so we still want to address the constipation, but at least with these options, you can have at least more efficacy with absorption even while constipated, though we should not avoid treating that constipation. Again, the one thing I have to reiterate is that while these options are so great, there are limitations. Again, this will only increase your on time. It does not make you bigger, better than you were, unfortunately, prior to the disease as we wish we could. So at the end of the day, the expectations for any of these devices, any of these levodopa infusion options, this is going to increase your on time, but does not make your on time better. I have an image here because I like to show what some of the symptoms that we're looking to primarily target here are these motor symptoms. So we're talking about the motor symptoms of the tremors, the slowness, and the stiffness, but we're unfortunately not going to be reducing any of our non-motor symptoms. So what are the side effects? And I know a lot of people might have read in these pamphlets, what are the side effects of these infusion therapies? Well, first I want to talk about what are the side effects of carbidopa-levodopa. So constipation, talked about that, nausea, daytime sleepiness, hallucinations, and dyskinesia. So these are the main the list of side effects can be quite long, but these are the primary side effects that we're often talking about. So now you read, what are the side effects of the Vyalev and the Duopa? Every side effect of the carbidopa-levodopa is still a side effect if you're getting that medication infused either through the intestinal gel with Duopa or the subcutaneous delivery through the Vyalev. However, the additional side effects that you are at risk of with these options are infection, and they're going to be different types of infection. So as you can imagine, I'm going to pull the device here so you can look at it. This is the Duopa device. This is the part of the device that's essentially the brain of it, which is part is programmed, and then the bottom part is the gel cassette, which carries the medicine, and then the tubing itself that connects to the stomach. What I'll tell you is if you're introducing a feeding tube through your abdomen into your stomach, you have a risk of infection. But all the other side effects are still a risk. Another side effect that I should have put up here that was completely on me that I should have, it can also lower your blood pressure. So a lot of you guys out there might have low blood pressure when you're on carbidopa-levodopa. These two will also lower your blood pressure. So now the infection risk in Vyalev is different. So now you're no longer using an intestinal tube that goes into the stomach through the abdomen into the small intestine. The Vyalev is an external subcutaneous delivery, meaning it sticks onto the skin, but there is a needle that does go into the skin to deliver the medication. So that is where your infection risk is with the Vyalev, is through the cannula, which is the name of the part of the Vyalev device that sticks to the skin with the needle that delivers it through the tube. Both devices or both infusion therapies, you have to carry the device at all times. So often the question is how do we carry it? So again, the Vyalev, I'm holding it in my hand here. You connect the tubing, and then that connects to the cannula, which connects to the skin. So this device you have to carry all the time in order for it to deliver the medication. There's a lot of different options for carrying the devices. And as you can imagine, the Duopa, that the J tube goes through the abdomen into the stomach, you also have to carry the pump as well. Now, both the Vylev and the Duopa have different options for carrying the devices. This is a pretty simple one. You have a little area where you can see through to see the buttons, and then this can strap around in different ways to carry the device with you. So both of these are a little bit large. They're about the size of 2 cell phones stacked together, but they are with you all the time while the device is running. But really what I wanted to iterate here is that all of the side effects from the medication itself are still the same, either oral, through the Duopa, through the intestinal gel, through the Vylev, through the subcutaneous delivery. All the side effects of the carbidopa, levodopa are the same. The difference of side effects are if you're going to be delivering it through the skin versus a tube that goes into the intestines. So I know some people have come to me and they say, oh, I don't want to take Vylev because it causes dyskinesias. Well, the oral medication also causes dyskinesia. So with these devices, it does not increase or decrease the risk of these side effects. However, because we're able to more closely or we can really titrate the medication, meaning we can really have a little very, very fine control of how much is being delivered into your system, that sometimes we can better treat or better control the side effects versus the oral medication, which is a little harder to tightly control for the delivery of the medication. So a lot of people say, how do I get started? What do I do to get started? And so the first thing to get, if you're wanting to get started with any of these devices or any of these options, is to talk to your healthcare provider, because not everyone is going to do well on all these devices. And so it really is important to ask the question with your provider, is this the right device for me? Parkinson's disease is, and this is my favorite one, the snowflake disease, meaning everyone is so very different. And that means that what is a very, very good option for one person, it might not be the best option for another person. So at the end of the day, if you're interested in getting started, the first thing you need to do is really talk to your provider and see if this option is best for you. One thing I wanted to go back to is the pictures. Are you able to see my cursor if I move it? Is anyone able to see that? Janice, are you able to see my cursor?
Yes, I am.
Okay. So this is here. This is the Duopa. The part that is, when my cursor is over, this is the part of the device that carries the batteries that is going to be changed. The batteries need to be changed quite frequently, but this is programmed to deliver the medication based on what your oral intake is. So when your provider, if you're going to be doing Duopa, your provider programs the device to deliver the medication at a particular rate, meaning it will be slowly infused based on the rate that the provider decides, which is based on your oral. You have the options to give yourself an extra dose. So it does give you the ability to give yourself an extra dose. It also, the Duopa, does give you parameters to go up or down if your provider programs it to do that. So when you're wearing it, you do have a little bit of control over how the medicine is delivered, but at the end of the day, this is pre-programmed by your provider based on your oral medication. And you do have to hook up and unhook up the device every day. So the pump has the batteries, the cassette has the medication. You take the cassette out of the refrigerator, which is where it's stored. The cassette needs to come to room temperature so that the medication is not cold. It doesn't feel good when it's cold going into your intestines. And then what you do is you connect the device with the cassette. And then the tubing is already connected into your stomach, and then you connect the two tubings together, and now your device is hooked up. Once you press start, the machine runs and it delivers your medication. The Duopa is usually programmed to deliver medication for 12 to 16 hours a day. Some people need to change the cassette. The medication might not be enough for one cassette a day. As the device runs out of medicine, you just take it off and put a new one on. At the end of the day, you take the whole device off, put it aside, and then you go to sleep. The picture on the bottom here, my cursor is circling, is the Vylev. So the Vylev is a little different. This is the newer device. It was FDA approved for the United States in October of 2024. So we're a year into doing this as an FDA approved option. The way that the medication is set up is the inside the device is a syringe. And the syringe is loaded with a vial of medication. So the medication is delivered to the house in a vial. I don't have the vials with me because those are not, we don't have those for display or option. You fill the vial, you fill the syringe from the vial, you place the syringe in the device, and now this device is programmed also by your provider. So what we do is we take the amount of oral medication and then we convert it to what that would be as it's delivered over 24 hours. So this device can be worn for 24 hours. The Duopa has one setting for delivery options. The Vylev has 3 different settings. So it has a base, it has a base, it has a high, and it has a low rate. So throughout the day, you can be running on base, which is what the device is essentially meant to be running at, but maybe you sleep on low. You don't need as much medication while you're sleeping, but you still want to continue to have that dopamine available for your brain, so you can set it down on low. This device also allows you to give an extra dose. Neither device is going to be keeping track of what happens. So it's really important as a patient that you keep track in a journal, or both of the devices come with a journal or a tracker, daily tracker that you can take at home. So you can keep track of how many extra doses you get. Unfortunately, they're not smart devices. They don't keep track of that. And that's helpful for us to know how often you're maybe needing more medicine. The device is also pre-programmed by your provider. So the only changes you make on here are if you want to go between the high, low, and base. The cannula and the tubing, which is the part that connects to the body, this needs to be changed every 2 to 3 days. And the medicine is changed out, refilled into into the syringe from the vial, either about every 12 hours or 24 hours. That depends on the rate that the device is running. And that's sort of what the devices look like in these 2 pictures here. So as you can see in this picture, the cannula is on his stomach, whereas in this picture, the tubing is going through the abdomen. And then with that being said, I know you guys all probably have a lot of questions, so I don't want to take up too much time talking here. So I want to open the floor to questions for you guys. So with that, I'll let you, Dr. Sue, take over.
Thank you so much, Dr. Smith. This was just really great. We have questions on the chat. We have questions that came in earlier while people registered. And then, there may be some people raising their hands as well. So I'm going to try my best to kind of go through them. Somebody requested that we go full screen while you were showing all the devices, but I don't think we were able to figure that out. So, sorry about that piece. We'll kind of try to see what to do about that. But, I'm going to start with some of the questions here on chat. So One person asks about how often do you need to switch out the Vylev or clean it?
Okay. So the Vylev syringe, which is the part that holds the medication, will need to be filled either once a day or twice a day. So either once every 24 hours or once every 12 hours. And that depends on the rate that the medication is being delivered. So what that means is if you need more levodopa, you're going to be running at a higher rate, which means you'll probably have to add medication more frequently. So you might be changing it, meaning filling up the syringe twice a day. If you're running at a lower rate, meaning you just need a little less levodopa, then you might be just filling up the syringe once a day. The cannula, which is the name of the sticky part that connects to the skin, and the tubing that connects to the pump itself, the tubing and the cannula have to be changed every 2 to 3 days. If you're more prone to infection, I would say maybe change it closer to 2 days, maybe even every day. But per the device itself, cannulas every 2 to 3 days, refilling the syringe every day. And if that didn't answer your question, ask a follow-up one.
Right. Okay. And then can you wear it in the shower? And if it doesn't work for you, can you go back to oral meds?
Yes. So because both of these are still carbidopa-levodopa, meaning we're not adding anything new or different, you can take oral medications in conjunction with both the Vylev and the Duopa. However, it makes it a little more difficult to know how the devices might be working and your response to the devices if you're taking oral with it. So we try to avoid concurrent, meaning at the same time doing oral and the pump, you can. And if you don't like it and it doesn't work and you stop the pump or you stop the Vylev or you stop the Duop, you can go right back to oral medications. You don't need a titration period. You don't need a washout period. You can go back and forth. The first part of that question, I think I answered the second. What was the first part?
Wear it in the shower.
Okay, wear it in the shower. Yes. So you can take off the tubing, and the cannula itself has a little clip. You clip in and you protect it. You can swim. I've had a patient go in the ocean. You can take a shower. Some people like to put a little Band-Aid over it to feel a little better, but it's not necessary. But you cannot wear the pump itself in the shower. You cannot get the pump wet. Same thing with the Duopa. You can bathe, you can shower, but the pump cannot be attached while you're doing those things. Just like any feeding tube, it does have a cap that you'd want to cap it at the end and clips to close it if you're not running the pump.
Okay. Well, there are two people raising their hands, and I'm going to go to them, but just ask one more question before that. Are these infusion therapies available for persons with both Parkinson's and Alzheimer's? If not, why not?
So yes, this is an option for someone who might have Parkinson's disease and Alzheimer's, as long as there's no contraindications to behavioral being able to have the devices. So that's a little hard to specifically say if that one person is a candidate, because there are some other factors that might be considered in determining if you're a candidate. But there are no contraindications for any forms of dementia with the pumps. And I think maybe that question might also come from someone who's familiar with deep brain stimulation, which there is some restrictions with dementia, but no contraindications or reason you cannot have the device with the concurrent dementia diagnosis.
Great. Okay, so now I'm going to go to Brent, who's raising his hand. Brent, if you would unmute and ask the question.
Can you hear me now?
Yes.
Yeah.
All right. So I do have two questions. The first question is, when I'm exercising, how do I wear the pump? Is that something that just goes in my pocket, or do I have to wear like a fanny pack How do I wear it? And then my second question will be, I am having some difficulty on finding the balance because in my peak times, I do want to flip into dyskinesia with the trunk tremors. And then, of course, when the medicine begins to wear off, then I'm going into the Brady shuffling the feet type of thing. And so, how does this pump? How does it? Why is it better for those types of problems?
Okay, perfect. So I'm going to start with your exercise question, and you can wear the device while you exercise as long as it's not flying around. So I would suggest wearing some sort of carrying case that keeps the devices, the pumps, closer to your. Am I still showing?
Yes.
All right. Keeping the device close to your body. Some people have gone online and found maybe those bands that people wear running that are made of a material that's meant to get wet and sweaty and meant to be exercised in while keeping the device close to your body. So that is a way to do it. A fanny pack is a way to do it. It depends on how intense your exercise is. But yes, you can wear it when you exercise as long as you don't risk having it fly off your body and pull the cannula out or pull on the tubing. So really it's case by case on what that looks like, but there you can exercise while wearing it as long as it doesn't fly off your body. And then the second part of your question, which is really, the key reason that a lot of people will opt into these devices is that it reduces what you described as your motor fluctuation. So having the dyskinesias when the medicine's really good and in your system, you might get a little too much and then you have dyskinesias. And then as you're wearing off, you get the bradykinesia, the slowness, the stiffness, the freezing. So what these devices are meant to do is reduce those fluctuations between dyskinesias and we'll call your slowness and your freezing off, because it's providing a steady stream, if you will, of the dopamine in your system so that it reduces those fluctuations that occur when you take a pill that gives you a boost of the medication. Then because of the short half-life, it wears off and you need more. So you take another boost of the oral medication, you're fluctuating all day. So the hope is that a device like this for you, Brent, would reduce those fluctuations.
Okay, so you're not having really the boost like you do when you take the pills. It's just like a slow and steady.
Yes, and it takes a little bit. You work closely with your provider at the beginning, finding that sweet spot, if you will, of what that rate might be. But yeah, once we find a place where the rate is sufficient to reduce those fluctuations, then you should go throughout your day without having very many. Now, there's also external factors that can cause, wearing off or dyskinesias that we can't always account for. But yeah, the goal is to reduce those fluctuations with these devices.
Thank you, Sarah.
Mm-hmm. Yeah, I'm going to go to Marta. If you would unmute and ask your question. Okay, I think Marta is trying to figure out. In the meantime, I am going to ask you another question. Would the use of either of these devices reduce the need for adjunct medications?
So yes, that would be the goal, is to reduce any adjunct medication as well, to keep it monotherapy through one of these pumps. However, it might not always work that way, but yes, that would be the initial goal, is to reduce any adjunct medication, to reduce all your oral carbidopa, levodopa, to essentially have all of your treatment through one of these devices. Again, it's not always reality, but it would be the goal. Yes.
Okay, then we have a question about whether you would know about any updates or changes to these current infusion therapies that are in the making.
Well, right now, I think these are the only ones we have. I did say how they do not collect data. These are not smart devices. They're not keeping track of how much is delivered. I think that would probably be the next step for these. And another question people have is, are there smaller devices? Not yet. So these are the options that are out there. I know they're working to make them smaller and better in different ways, but right now, these are the options. What's in the pipeline, I'm not sure, but I think it's to reduce the size and possibly give more feedback to a provider, meaning more of a smart device.
Does body placement matter? Is a question somebody's asked.
So I'm guessing the body placement they're asking about is the body placement matter for the Vylev, which is the subcutaneous version, the one that has to be changed. So right now, the primary spots to place the cannula are on the abdomen, so just below the breast line to the top of the hip bone. You can also extend that around to the back or the flank in the back. It's also approved to be placed on the front of the thigh or the back of the arm. For convenience and because you are connecting to the pump itself, the most common area is the abdomen. They do ask that you move it around so that you're not always putting it in the same spot. So for some patients, I have found they like some spots better than others. And I will say not every patient likes the same spot. So I think sometimes placement does matter. Again, it's not across the board, kind of like Parkinson's disease. Everyone's a little different. So it's just a matter of finding what spot works for you. But the most important thing is that, yes, there are specific spots you can place it, which are the stomach, a little bit of area in the flank or the back, the front of the thigh, and the back of the arm.
Okay, I'm going to go back to Marta to see if she is able to unmute now.
Yeah, I would like to know, because I couldn't hear the beginning, if constipation, there is some special connected medicine or system to avoid the constipation, to decrease or have less impact.
So I'm going to ask the question again to make sure I have it correct. Are you asking about, does this increase or decrease constipation?
Yeah, decrease constipation. Constipation is as I understand, the constipation is a effect of provoked by the Levodopa.
Yes. So
And
yes, the medication does cause constipation. So by delivering it either through the intestinal gel or through the Vylev, it does not reduce the risk of constipation. However, it can reduce the absorption issues that occur with constipation. So you still should be, you may still have constipation with these medications. However, the constipation might not affect the absorption as much, but you still need to treat constipation for other reasons while using the devices, but they do not reduce that side effect.
what can I use to reduce the constipation without interfering in the medication?
Sorry, I apologize. Repeat that one more time.
What I should use to decrease the constipation without interfering with the medication?
So I would talk to your provider on the best way to treat constipation for you, because that's also going to vary. So I would say if you're dealing with constipation, I would talk to your provider about constipation.
Okay. Okay.
Okay, thank you, Marta. Do you know, Sarah, if there are how accessible these infusion therapies are for people, who may not have a premium insurance or, just the cost and stuff? Yeah.
So the cost is a difficult question to answer. That answer does vary. It depends on your insurance company and what they'll cover. Right now, both devices are covered by all insurances, but to what extent, I can't give you that quote. But some people have zero out-of-pocket costs. Others have up to $3,000 to $5,000 for the year out-of-pocket costs. Some might have a higher out-of-pocket cost, and then they opted not to do the device. And I don't have those quotes on hand. But there are also the company itself can provide some funds to help cover it. Again, that also is going to vary. So the cost and what insurance will cover, I don't have that specific answer because it will vary. The best way to know that answer is to run it through your insurance. I would say be careful. Don't just call your insurance and say if they cover it. Because these are advanced therapies and do require certain documentation to run through the insurance. So that question is hard to answer specifically. I don't want to hold myself to any quotes, but it is covered by insurance, or we can get it covered by insurance. If there is out-of-pocket costs, we do have some patient assistance programs that can help with that.
Great. Well, thank you. I think a lot of the questions that were sent to us early on were answered by this very excellent presentation. And I know people asked if these slides will be available. So I do want to mention that since we're recording this event, it will be available on our webpage as a video for you all to watch again. And, we may also be able to send you the slides. There's one more question about why take the medicine if it doesn't help the tremors. That's what someone asked. Yes.
Okay. All right. So I'm going to go back to another slide to kind of talk about this. So carbidopa-levodopa is the mainstay and gold standard medication for Parkinson's disease. In Parkinson's disease, the neurons that are producing dopamine, those dopaminergic cells, unfortunately, are neurodegenerating. So the cells that produce dopamine are dying off. And so as a result, you don't make as much dopamine. The symptoms of Parkinson's disease come from the lack of dopamine production by those dopaminergic cells in the basal ganglia. As a result, a common symptom of Parkinson's disease is the Parkinson's disease rest tremor. That is a tremor that not every person with Parkinson's disease has or will develop. So not everyone, like I said, has the tremor. And unfortunately, for some people, levodopa, despite trying very, very high doses, does not reduce the tremor. Why that is, we don't know. That's not the case for everyone. For some people, just a teensy amount of levodopa can reduce the tremor. So again, this disease is so variable. Everyone has a different symptoms. And unfortunately, for some people, the levodopa does not reduce the tremor. That doesn't mean you can't try these infusions, but I would say if your tremor does not respond to the oral levodopa, it most likely will not respond to these infusion methods of levodopa. And again, that goes to why we use those very general terms of you're on and off. So for some people, when they're on, the tremor is reduced, and that's how we know that the levodopa is effective. So at the end of the day, these infusion options are available for patients' symptoms that are levodopa responsive. So again, your expectations are whatever gets better on oral medication should also get better on these infusions, but you shouldn't expect symptoms that don't get better on levodopa to get better on these infusions. And that's really a big key component of deciding if these options are right for you, because We don't want you to expect that this medication, because it's infused through the skin or the intestine, is going to work entirely different than it did through the oral route. It's not necessarily going to work different. We're just now giving you more frequent on time with these devices because it's delivered a little differently, and we're bypassing all the steps that have to go through the digestive tract when you take something orally. So if your tremor does not get better on the oral carbidopa levodopa, I can't say it'll get better on these devices, and that's definitely a conversation to have with your provider so that everyone goes into this with the correct and with the same expectations, because at the end of the day, you're only going to do as well as you expect to do, and you're not necessarily going to do better than you expect to do. So we always have to have those expectations set at the start.
Okay, we are out of time. We have some general questions that are not necessarily related to the topic at hand. So for those, please keep looking for our other Ask Your Doctor series that are coming up. So there may be an opportunity for those to be answered. And also, of course, talk to your provider about other specific issues you may have. With that, I am going to conclude this session and thank Dr. Smith for an excellent presentation. We really welcome your feedback, and there will be a form that you will receive right after this ends. So if you can just fill it out right there and then and tell us more about what kind of programming you want to see, what other topics you want your doctors to address, please let us know. We welcome that, and that's how this entire programming keeps progressing when you tell us that we're doing good or bad, what we can do better. With that, thank you very much, and thank you, Dr. Smith.
Thank you very much. It was a pleasure being a part of this. Thank you all that joined.
Thank you, everyone. Bye.